Very good morning to all of you. Today we are going to start an IC on phacoemulsification from theory to practice, a practical approach to phacoemulsification mastery. So I invite Dr. Anu Pravi to start the presentation. He will be speaking on transition from manual to phacoemulsification surgery, how to overcome the challenges.
Yeah, hi, good morning all. So, as ma'am said, thank you madam for the opportunity. As madam said, I'll be talking on transition from manual to phacoemulsification. I'll be talking on overcoming challenges. As an SICS surgeon myself who had converted to phaco for the last 5 years, I think if I can do phaco, so can anyone. Who can do phaco? Anyone with a good microscope and a good phaco machine. It's once you master it, it's very easier than SICS. It's just, I always say, to my residents, I always say it's just scalp, chop, quadrant, epinucleus, IA, and IOL, putting the IOL and the visco wash. Anyone who can drive a car and can use both feet and 2 hands can do phaco. Just have to have control over your foot pedal with the right foot, over your microscope with the left foot. Use your left hand for chopping and controlling the nucleus, and right hand holding a phaco. But the main challenge, 3 challenges would be to have a mentorship. You need someone to train you, to guide you, to tell you how to convert from SICS to how to go around. And I was very lucky to have a mentor of my own. She always said the first thing is to observe how a good phaco surgeon does surgery. And you need to collaborate with experienced surgeons. Training and education is very important. Workshops, conferences, and online courses gives a good info on that. And before starting on, you need to practice on simulated eyes, develop skills on artificial eyes or wet labs, and be ready before you start. In my opinion, YouTube videos, there are good surgeons who have uploaded a good amount of YouTube videos. It gives a good hand before you go in. And before we start, there are 3 challenges. To have a good microscope, that's more important than phaco machine. To have a good microscope with a good red glow, it's a surgeon's eye, and use it before you cut. Second thing, the position the patient. You have to keep the patient's head flat before we start. Phaco machine, have hands-on, understand the parameters, settings, adjust the bottle height, power, AFR, and vacuum to our own settings before we start. And always have a standard protocols. Every surgeon will have a different set of parameters and protocols. Before we start, we need to understand the machine and have our own set of parameters. My mentor always said you need to visualize the surgery before we start. So you need to know how you're planning to go around before we even touch the patient. Visualize the whole surgery in your mind. Case selection is the next challenge. You have to start with the simple, straightforward cases and progress to complex ones. The ideal case would have a good dilatation, grade 2 to 3 nucleus, no pseudoexfoliation, no other complications. And as I said, ensure the patient's head lies flat. Initial cases should always be done under peribulbar or subcutaneous anesthesia, and once confident with that, move to topical. I feel, in my personal opinion, I feel preservative-free lignocaine drops works better than proparacaine in doing topical. I always use intracameral adrenaline for patient comfort. Before we start, we need to have a backup plan. Whenever we are going bad or when we are going wrong, we need to have a cannula with our side. I always keep a cannula with local loaded. Have an iris hooks or BX ring in case the pupil comes down, Rexis forceps, Vanna scissors, CTR, cohesive viscoelastics, micro scissors and forceps, and a vitrectomy set which is working. Many times when we have a complication, when we try, the vitrectomy set wouldn't be working, so make sure that it's working. And I always keep a secondary IOLs, foldable 3-piece, iris flow lens, and rigid PMMA in case I have some complications. Once we have a backup plan, then it's very easy to go around. Now, next challenge would be to sitting temporally, because most of the people who are going to convert would be doing SICS superiorly. Adjust the microscope and foot pedals according to where you're sitting. Do initial first few cases as temporal SICS. I myself had my first 100 temporal SICS before moving into phaco. Make a clear incision. This is my case where I've done a few, just to show the video, I couldn't due to time limits. So make a clear incision as we do in SICS. Then make a small trench, like we make a small initial keratometry. Then progress to divide and conquer through the clear incision. And once confident, you can always progress to clear corneal incision. But then again, there lies a challenge, because there are two, the way we are going to enter the clear corneal would make a difference in the outcome. You need to enter near the limbus. See the scleral vessels, just make a small puncture, then go in, make a triplanar incision. Initial cases make the wound very small so that it can prevent the wound leakage. And train to use 2 hands simultaneously, because always phacoemulsification is to be done by 2 hands. Initial cases for SICS surgeons, it's very difficult. So I always tell my residents to type on smartphones with the left hand so that you get more control with the left. Next challenge would be the capsular rhexis, because you definitely need a CCC for doing a phaco. Initial cases, people say you can have a small pupil, but initial cases make a pupil which is at least 5.5 to 6 millimeter. And use plenty of visco to flatten the anterior capsule. And when you have small anterior capsular tears, be ready with your tools. You have micro rhexis forceps and scissors, which helps in increasing the CCC. You can use both bent 26 gauge needle or cystome, whichever works well in your hands. I personally feel Hadi-Pucker rhexis forceps is better than Utrata in making a rhexis. Now, the next challenge would be to do a hydrodissection. I personally tell every of my residents to do both hydrodissection and delineation in the initial cases. The first attempt always through the main wound, let out the visco before procedure, and fluid should come out through the opposite side. And rotating the nucleus is very important. The more you rotate, the more cortex loosens up, and it will be more easy for the IN, irrigation aspiration. Now, taming the nucleus, initially when you go in, aspirate the superficial cortex with vacuum, and start with divide and conquer for early surgeons. Keep the instruments at the bottom of the groove. Direct chop and flip techniques at the later stages. Initial cases, please optimize the phaco power and low and AFR low. Use continuous irrigation while entering. That's the initial tip. Use a long Sensky hughes for routine cases. Blunt and sharp choppers only for dense nucleus division. Now, sticky cortex makes the next challenge. Flush the capsule with BSS after nucleus removal before cortex first, so that the cortex comes out very easily. And it's always confused with epinucleus. Do an hydrodissection again after nucleus removal, so that the epinucleus is loosened up. Bimanual IA with Simcoe, if difficult, you can go over that. Grab the cortex within the capsule. Adequate bottle height should be given so that the bag, posterior capsule is gone down. Fill visco to form the bag, then only move it. Now, next challenge for SICS surgeons will be foldable IOLs. Initial cases start with basic unifocals only. Fill enough of visco to form the bag. Keep the posterior capsule filled. Enlarge the primary wound in the initial cases, because I felt that initial to injection very difficult, because the IOL would be stuck inside the tunnel. So enlarge the primary wound. Check the type of IOL and loading of cartridge prior to surgery, because we are used to PMMA lens, which doesn't have loading of lens. But then most of the lenses have different types of loaders, and we have to check for the type of IOL and loading the cartridge prior to surgery. Manipulate the plunger and injector as the IOL comes out. You have to modify your technique so that it comes down flat. Use the left hand dialer to support the IOL so that it doesn't hit the PC. Hydro implantation and wound assisted delivery only once fully confident. Now, I would like to take a word about viscoelastic substances. Use adequate amount of visco during rhexis and in nucleus management. Each time you come out, fill in visco. It protects your endothelium and your PC. When in doubt, stop the surgery and fill in 2% HPMC. Have a cohesive viscoelastic in case. And ensure that your visco is completely removed after surgery to prevent post-op corneal edema. And my tips for smooth transition is to start with straightforward cases, lower the ultrasound power, monitor IOP and corneal health, manage viscoelastic carefully, maintain proper surgical ergonomics, stay focused on nuclear emulsification, be prepared for complications, and be confident to convert to SICS in case of any issue. My mentor always tell me properly done SICS is better than complicated phaco. And post-conversion, I'm very helpful for my mentor over here for make me convert to phaco completely. I myself do 99% of phacos, right? All cases, 99% of all my cases are phacos. Please collaborate with experienced surgeons and seek guidance on challenging cases. If you have video recording, record your cases, record all your cases, and have a feedback from that. Peer feedback is very important. Review your own recordings. Participating in peer review and feedback sessions. refining surgical techniques, and it improves, your skill improves on continuous learning, staying updated on latest technique and technologies, attending conferences and workshops. Thank you.
We'll keep the discussion towards the end. The next speaker is Dr. Divya Menon. She's a high-volume phaco surgeon working at the Abate Eye Hospital. She's also a close friend of mine.
A warm good morning to all of you. My half of the job is done by Anup. Anyway, the expert at anything was once a beginner. So I'll be dealing with a step-by-step guide to setting up your first phacoemulsification surgery. So I'll be going through prerequisites, case selection, equipment setup, instrument verification, what to expect, and how to tackle the unexpected complications. So the major prerequisite for the first case is knowledge foundation. As Dr. Anup had already said, we have to master the phacoemulsification principles initially. You should know the ocular anatomy and the cataract pathology because each eye is different. Each cataract is different. You can have soft cataract, hard cataracts, leathery cataracts, and all cataracts give a different feel when you go inside the eye. Understand each surgical step and instrument functions thoroughly. Hone the microsurgery techniques through wet labs and simulators. Dr. Sharika will be dealing with it in detail. Focus on your hand-eye coordination and instrument control. Ensure the phaco machine calibration and staff readiness. Familiarize yourself with the OR layout. And as Dr. Anup had already dealt, you must go through many visuals and diagrams. There are umpteen number of good videos on the YouTube by Deepak Megur, Dr. Saurabh Patwardhan, Dr. Uday Devgan. They are excellent videos and they give you very good knowledge about how to go through your first initial surgeries. The main thing which I tell my juniors is about the hand positioning during phaco. You should always hold the phaco probe in your right hand, provided you're a right-handed person. The phaco probe should be in a pencil holding or in a pincer grasp position. Rest your right hand on the patient's cheekbone and left hand on the patient's forehead so that your wrist joint is stabilized and your movement is only at the fingertips. The correct handpiece angle minimizes the endothelial damage. Each movement of your phaco can cause endothelial damage, so you should have a correct angle for that. And always maintain a safe distance from the posterior capsule as well as from the endothelium. You should always have a troubleshooting guideline so that whenever you end up having any trouble, you can have a systematic approach to resolve issues efficiently. Now that you're confident about the phaco surgeries and ocular anatomy and the ocular cataract pathology, don't be in a hurry to go and do your case because it is very important to select your patients. In your initial surgeries, do suitable patients with just moderate cataracts, clear cornea, normal AC depth, intact zonules, well dilated pupil. Avoid complicated cataracts in your initial surgeries, and I would also say avoid apprehensive patients, avoid known patients and VIP patients because they will definitely cause trouble. Patient education is very important. Sit with them, explain the procedures, risk and expected outcomes. Address all the patient concerns to ensure the comfort. Equipment setup is very important. Double check the IOL power and always be ready with a plan B. Be ready with secondary scleral fixated the iris claw lens or 3-piece IOLs so that in case you end up with any PCR, you have a plan B to go about. Adjust the microscope height for optimal visualization. You must know your microscope before you before you start your surgery. You have to orient the oculars in the right position if you are operating from a temporal or a superior approach. Identify the center focus or the XY button and remember to press it at the beginning of the new case so that your microscope is reset before the surgery begins. Check your interpupillary distance and adjust the oculars to 0. In both the objectives should be 0. Practice to move the microscope manually with hands. All of these skills, although seemingly simple, but they are very critical in keeping a smooth case flow. You must know your foot pedals because as Dr. Anup said, It is like driving a car. So all four extremities are in job. So you have your under your left foot you have your microscope foot pedal, and under your right foot you have a phaco foot pedal. The phaco foot pedal again has three positions, as you all know. Position 1 is irrigation, phaco 2, the position 2 is aspiration, and position 3 is phaco. You must be thorough with your phaco machine settings and phaco dynamics. There are four main things: power, aspiration, vacuum, and bottle height. Power is the ultrasound energy which is used to break up the cataract. Aspiration rate is the rate at which the fluid enters the phacoemulsification tip. It controls the speed with which the pieces of lens comes into the phaco tip. Higher aspiration rate can be kept for faster and experienced surgeon, but as a beginner, it is always advisable to go for a low AFR and in scenarios where you have PCRs. Vacuum defines how strongly the nucleus pieces are held by the phaco tip. Higher vacuum settings are often required during the chopping maneuvers in order to establish a strong purchase of the lens nucleus. Many phaco machines rely on bottle height, where the inflow of fluid into the eye is based on the gravity fluidics. So depending upon the cataract and depending upon the eyes, you have to adjust your bottle height. New mid-generation machines now use infusion pumps to maintain a chosen IOP in the eye and for the anterior chamber stability. So these four factors are modulated based upon which step of cataract surgery you are performing. You have to take time and sit down with the manufacturer's representative of the platform you'll be using during your training, so that you can customize the phaco power settings or phaco settings to up to your convenience during your initial surgeries. This is very important. So because they will have they must have seen so many cataract surgeons operating, so they will adjust this phaco machine settings up to your convenience. And instrument verification is again very important. Confirm the availability of all the necessary instruments. Ensure the sterility and proper functioning of each instrument. You must be comfortable using all these instruments as well. The usual problem we have is during the dislodging of the IOL. If it is very hard, the IOL just shoots in and you can end up in PC tear. So you must verify all this beforehand. Anticipate longer operating time initially. Focus on precision rather than speed during your learning phase. Be prepared for variations in the lens density, capsular access. Monitor the intraocular pressure closely throughout the procedure. Expect high success rate with proper preparation. Now, the step-by-step guidance Dr. Anoop has already dealt with, the incision and capsular access, nucleus assembly and all. You have to deal with the unexpected issues, like if you have a capsular tear, apply cohesive OVDs, reassess and adjust your technique. Poor visualization, adjust the lighting and use pupil expanders. If you have any machine issues, perform quick troubleshooting or seek immediate assistance. Consult experienced colleagues for advice and reassurance. Discuss the potential challenges and strategies beforehand. You have to analyze each case. Before starting your case, sit back and decide in which type or what is the plan of action you're going to do with this patient. See many surgeries before you enter your OT, and you must talk to your senior colleagues or senior mentors if you know that if you anticipate that you're going to face any problems, they can give you guidance accordingly. So preparation is the key. Invest time in thorough preparation. Knowledge and practice build confidence and improve the outcomes. Embrace the journey. View each case as a learning opportunity. Progress comes with experience and reflection. Set goals for each procedure. Strive for refinement in technique and efficiency with every case. Thank you.
Wonderful presentation, Dr. Divya. So the next speaker is, as phaco surgeons, we are all worried about a PC rent and following that a nucleus drop. But the next speaker, Dr. Sharath, doesn't have to worry about it because he himself is a VR surgeon. So over to you. He is working at New Vision Eye Hospital, Manjeri.
Thank you, Dr. Divya, for the chance. Today I'll be dealing with phacoemulsification in challenges cases, mainly hard cataract and small pupils. we all know that nucleus management in heart cataract is very difficult. As heart cataract, it will need lot of phaco energy and time to completely emulsify the nucleus. This use of increased phaco energy can lead to lot of corneal problem, corneal wound burn, endothelial problem, postoperative corneal edema. Even it can lead to corneal endothelial decompensation. Generally, in this hard cataract, zonules will be weak and we may produce additional stress over the zonule while attempting chopping, can lead to zonular dialysis, and complication like posterior capsular rupture is also common in hard cataract. Postoperative inflammation is also very common in hard cataracts. In the hard cataract, most difficult part is to completely separate the nucleus into multiple fragments. Usually the posterior leathery plate will be very thick. It is very hard to crack the posterior leathery plate. So my technique is to make a very deep and wide central trench. Make it very deep so that the posterior plate is very thin and it is easy to crack it. I'll show you a video. It's a grade 4 cataract, brown cataract. For such hard cataract, you need a little larger axis so that you will have some space for your maneuver. Before making the trench, you sculpt the surface of the nucleus a bit so that overall thickness of the nucleus is reduced. Then you start to make the central trench. Make it very wide and deep. By doing this two things, the hardest part of the nucleus you are emulsifying inside the bag. Then the heat energy transmitted to the endothelium will be reduced and you are making the posterior plate very thin so that it will become easy to crack. So you take time for this step, make the central trench very deep and wider. Once it is ready, then you go for the chopping. You can see the trench is very deep and wide. You can see the red glow through the base of the trench. Now it is ready for chopping. For chopping in hard cataract, you need very good hold of the nucleus. Your grip in the nucleus should be very good. For that, you should have a very high vacuum. Usually I use around 475 to 525 vacuum. The vacuum should be very high and the tip should be buried deep into the nucleus. For that, the tip should be exposed little more. These two things, you will get a very good hold of the nucleus. One is very high vacuum and the tip should be buried deep into the nucleus. Once you get a good hold of the nucleus, then start lateral separation. Lateral separation you do in multiple attempts, not in a single attempt. You do lateral separation, then in the next attempt you go little deeper and separate, and then you further go deeper and separate. Like that, with the chopper you go progressively deeper and separate. When you do like this, the stress over the zonules will be less. Usually I use a 1 millimeter sharp tip chopper. It's little longer, so you can go very deep within the bag. You divide the nucleus into 6 or 8 small fragments, then your emulsification will be much easier. With a larger piece, the cotton removal will become difficult. Smaller piece, it is easy to emulsify. See, I am separating the nucleus, then keeping the chopper further down and separating, then again separating. I am separating in multiple attempts. Once all the pieces are completely separated, now it is ready for cotton removal. Cotton removal always protect the endothelium using a dispersive viscoelastic. Once all the pieces are completely separated, your cotton removal will become much easier. You just have to stay at the center of the eye in the pupillary plane. Always stay in the pupillary plane and start emulsifying the pieces one by one. Once all the pieces are completely separated, you will have a very good followability, and the pieces are small, you will have very good followability. And it's like any other normal case, easily it will get emulsified. In between, if you want, you can top up with dispersive viscoelastic to protect the corneal endothelium. Just stay in the center and emulsify the pieces one by one. Always be careful while doing the last piece. There is always a chance of surge. So last piece, be careful. If you want, you can reduce the vacuum a little bit lower. After that, usually there won't be much cortex. You can remove the cortex wash and go for the IOL implantation. Sometimes you may not get a crack in the posterior plate in first attempt. Such cases, you can use a 1 millimeter chopper with a blunt tip. With this, you can go very deep and separate the nucleus without fear of posterior capsule damage. So, you can go with the chopper very deep and separate. It's very safe. Even if you touch the posterior capsule, it's not going to cause a PC tear. And I told the hold is very important in managing hard cataract. Here I am, when I am attempting chopping, the nucleus is slipping. That means your hold is not good. Such case, you have to reassess why the hold is not good. If vacuum is low, you increase the vacuum. If your tip is not buried, you can bury the tip deep inside and then attempt chopping. Then coming to small pupil, I will show you a video of how to place the iris hooks. Iris hooks, you make small stab incision at the limbus or little posterior to the limbus. Just small stab incision are needed. 4 incision at opposite clock hours. If it is made at opposite clock hours, you will get a uniform dilatation of the pupil. Once the 4 incisions are made, you start introducing the hook through the side port. You can introduce the hook through the side port. You can change the direction of the hook by just rotating the stopper. With the stopper, you can manipulate the direction of the hook and engage the pupillary margin and pull. Like that, introduce the 4 hooks. Always the incision is important. It should be at the limbus or little posterior to the limbus. If it is anterior, you will get a tenting of the iris. So always at the limbus or posterior to the limbus incision is. For at the opposite clock hours, your dilatation will be uniform. And after the surgery, after IOL implantation, you can remove the hook, remove the stopper, disengage the pupillary margin, and you can remove the hooks. Always in managing challenging cases, you should have, as madam told, you should have a plan B. Always keep vitrectomy ready. Always keep iris claw or standby sulcus fixating lens ready. With proper planning and management, you can give very good results for such cataract. Thank you.
Thank you, Dr. Sharad. That was a very interesting topic. I would like to add on just 2 points in this. One is, while inserting the iris hooks, I think it is always better to do a capsular access after you insert your iris hooks, because sometimes when you insert the iris hook, you might also hook the capsule, and that can result in a capsular tear. Second thing, when you're doing the trenching, you can go deep and till you see a red glow. So that is the point where you have to stop and you have to start breaking your nucleus. So that was an excellent topic, excellent videos. Thank you very much. Now I invite Dr. Shaji Hussain. I think he doesn't need an introduction. Everybody has known his skills from yesterday's videos. He is an excellent surgeon, high volume surgeon, and he tackles with all the complicated cataracts that comes to our hospital. So over to you, Dr. Shaji.
Hello. Thank you, Divya, for those kind words. So, as you all know, my topic is customized intraocular lens implantation. How many of you have implanted multifocal lenses and EDOF lenses experienced? Okay, what is your main worry? Because these are the category of patients who chorify you a lot, because they come back, they say that the outcomes were not as they expected it to be. Though the vision is 6/6, we never know what happened. So let's just delve into it. What would have happened? So definitely Phaco is the gold standard. We cannot survive without knowing Phaco. And now the idea is not just about Phaco. It is about a patient satisfaction. The patient's expectations are way too high. They are looking at something more than 6 by 6. So it's not longer, it was maybe during the early times they were just implanting 18 diopter lenses. So that cost system of one size fits all doesn't stand at all. We are in the variation of customizing IOLs based on patient needs. So we are trying to tailor. There is like maybe some patients are fit for EDOF lenses, some are multifocal lenses, some are contraindicated for this. So we should have an idea of when to advise what. So we are in the personalized vision era. There are a lot of things happening and we are catering to the patient needs. So to start with, what are these customizable lenses? Start with, we know the first was the aspheric lenses. They were wow factor, the outcome, it was taking care of the spherical aberrations induced, and we had great results. And there has been comparative release assessments about aspheric and spherical. Then came along the multifocal lenses. So it was tackling most of the reading problems. But again, we had factors like night driving were an issue. So there were patients who needed quite a good, at least a computer assist reading or the intermediate vision they needed, but we didn't have an answer there. And they need a quality life improvement. So the challenges and considerations with multifocals were with regard to its visual disturbances, contrast sensitivity, and ideal patient selection. We did have headaches following multifocals. Then came in the EDOF lenses. Now is the EDOF era. So we know the VVT is an EDOF lens from Alcon. iHands, so far I was thinking it is an EDOF, but now it is not. They are coming up with Pure C. So we did expect it to be it was now told to be a mid-range EDOF, actually not an ideal EDOF. Now they are coming out with Pure C. But it was a good lens, to be frank. iHands did quite a good satisfactory patients out. But still there are issues that some patients are facing. So the outcomes of EDOF lenses, now we are all discussing about it. And we are looking up for as customizable lenses in the monofocal aspheric lenses, multifocal and extended depth of focus lenses. And all the above, implantation of toric lenses. We should know how to implant according to the refractive errors or the corneal astigmatism. So we should, before taking up these patients for any surgery, we should know the pre-existing conditions of these patients, like dry eye has to be assessed. Definitely an OCT macula is definitely important to rule out a macular degeneration, though it is not clinically evident. The lifestyle, we should be knowing whether the patient reads a lot or does he drive a lot. These are the two main things. And does he use computers? So the first case scenario here would be a 45-year-old IT professional with significant corneal astigmatism, and he is having cataract. So definitely we have to implant here a toric IOL, and we have EDOF toric lenses also available now. The next case scenario would be of a 60-year-old golfer and photographer. He definitely needs distance, as well as he would be happy if we could give him an intermediate vision. So here EDOF lenses are the answer. Next would be a 55-year-old homemaker enjoying crafting and cooking and reads a lot probably and doesn't drive. So here definitely you can advise a multifocal lens. 35-year-old fashion designer with high myopia, cornea, and here LASIK cannot be done because of thin corneas, and this is something out of the phaco. Here I would be implanting an ICL for him. There are a lot of customizable now scleral fixated lenses. All these are kind of customized lenses, but beyond the scope of this presentation. So while planning these patients, optical biometry, of course, corneal topography, aberrometry, OCT macula, these should be there in your armamentarium. And higher order aberrations is something you have to address, and the angle kappa has to be assessed. So this would probably be the only important slide I want you to take home. That is the total higher order aberrations we should be looking at. The mark would be 0.5. Anything between 0.3 to 0.5 is to be dealt with in a middle range satisfied patients. Less than 0.3 is the ideal patients for customized IOL implantations with regard to higher order aberration. Anything more than 0.5 are an absolute no for higher order aberration. Also with spherical aberrations, it is 0.1. This is the safest value. Up to 2 would be fine. Common trefoil 0.2 is the safest. and anything more than that would be in the mid category, and 0.3 of comma would be a bad result. And never forget the mesopic pupil size. Here glare is something, because these patients who have a pupil size more than 6 would give you a headache throughout, and that's from personal experience. And large kappa angle has to be assessed. All this can be assessed with modern topographers. Now there are certain intra-op consideration that you should be taking up, but that is with regard to the sizing of the capsules and the rotational stability of toric lenses. So what all should I be considering in a surgery while I am going on with a patient who needs a surgery? Or with regard to, I'll be a little careful with regard to the incision, with regard to the rhexis, with regard to the cortex wash-up, with regard to the visco wash-out. I will ensure all that, and about little about the Purkinje images. So what's to be taken care of in incision? Try to be an accurate incision without any irregularities. Ensure that you have a perfect entry, especially with regard to the corneal incision. Next, in rhexis, an ideal size of 5.5 with what I usually prefer to have. And if, let's say, you have an irregular or a larger rhexis, size would land up in the decentration of these lenses. For these lenses, centration is absolutely important. Cortex wash-up, try to be very careful, do a good polish and ensure everything in the cortex has been thoroughly washed out. Visco, as I said, should be completely washed out, and in these cases we can take up the step where Anup mentioned that a hydro assisted implantation of the lenses can be preferred. While placing the IOLs, and after a good thorough polish, we can do an hydro assisted implantation of the lenses and ensure the Purkinje images are, that is at the cornea and the lens, are absolutely aligned. And all the more post-operatively, ensure you are giving a good education to these patients, because they cannot ensure a good vision right about, they may have a little problem. So visual adaptation is something you have to counsel these patients after your surgeries. Finally, thank you.
Thank you, Shaji. That was an excellent preparation and excellent presentation. As usual, your videos are fantabulous. Now I invite Dr. Sharika. She is a professor. She's assistant professor in MES Medical College, and she's a cataract surgeon. She's a multi-talented person I have seen. So she'll be dealing with virtual reality simulation training for phacoemulsification surgery. Over to you, Sharika.
A warm good morning to all of you. Thank you, Divya Madam, for including me in this IC. So my topic is virtual reality simulator training for phacoemulsification. So this is basically for the postgraduates. So before starting your phacoemulsification, before going for a phaco training, what can we give to the postgraduates? Okay, I have no financial disclosures. So I'm mainly going to discuss what is the lacunae in the present residency training, how to fill the gap, how does a simulator work, is it validated, what are the advantages of a simulator, what are the facilities available now, and what are the drawbacks. Under pressure, we don't rise to the level of our expectations, we fall to the level of our training. So the initial training is very, very important. According to studies conducted, the average residence during the residency period, the average number of surgeries independently performed by the residents was about 1 for phacoemulsification in the 21st century, which is very, very low. So where is actually the problem? So let's, this is just to lighten up. This is a trainee and this is a trainer. There's no sound coming. Okay, this, I think all of you might be familiar with this. This is a trainee and this is a trainer. The trainer is tensed. the trainees tense, the trainer is also tensed about the outcomes. There are too many trainees. The trainers are more worried about the patient outcomes. The patients are more demanding. Trainers have multiple commitments at hand. Trainees get caught up in a loop. That is, they have a complication. They are even more apprehensive to do the next surgery, and they again take longer surgical times. So they don't actually want to do the surgeries. And we trainers are also in the same loop. Okay, so how to overcome the problem? Mainly, we can have wet lab training, video assisted learning, and simulation based learning. So wet lab learning, we have started early itself in the goat's eye, doing rexes on polythene sheets, but the disadvantage is that we can do only limited number of steps, and the trainer has to be always present at that time. We have to constantly assess how the trainee is doing, and we cannot repeat many times. And now then came the developed simulator. It was just a computer to which the haptics were attached. Okay, it didn't simulate the OR setting actually. And this is what the initial simulator was. Then came the advanced simulators, that is the IC simulator, Help Me See simulator, and the Alcon Fidelis. They are now available at Aravind Eye Hospital, Madurai, LVPI Hyderabad, and Ajanta Pharma are also supporters for this. Alcon Fidelis is actually a portable simulator. The other two are also portable, but they are a bit hardy. So the validity of both these simulators, that is the Help Me See simulator and the IC simulator, were validated. So it was found that this is the intermediate group and this is the expert group. So the difference between the two were more profound in case of Help Me See simulator, which means it is much better in training the surgeons. So this is so I'll be speaking mainly about the Help Me See simulator. This is the main simulator. This is the part through which we can see the OT-like setting. These are the hand pieces which can be interchanged, and this is the monitor through which the trainer can assess how you are performing. So it's usually a 6-day session with at these centers. First you have an ebook self-study for self-study. Then you have classroom sessions, lab activities, simulators, and debrief sessions in these 6 days. So this is the simulator. So it appears this, it's almost very close to the normal surgeries. All the steps can be done with the foot pedal. It gives you at what level you're doing, okay, at what level you're trenching. Everything can be seen. For a beginner, it's very, very useful. And you can overcome the fear of actually starting your first case. And all the steps can be done, and whatever steps you want, you can repeat them and do it till you get it right. And even coming to the complications, like if you have the phaco tip is near the anterior capsule, it warns you that the anterior, it's close to the anterior capsule, or it's close to the endothelium. So you can adjust your hand position, you can correct your hand position prior to starting your first case to avoid these complications. And then if the trench is too deep, how to go forward with that. So if a trainer is also present, you can again ask them how to do it, and they can refine each step till you get it right. So if you have all these complications, the machine gives you a beep sound and you have to stop. But you can again repeat that step. So in a study conducted to compare the 10 phacoemulsification surgeries with and without prior phaco training, it was found that with a prior phaco training, your complication rate was much reduced to the one without the simulator training. And now then there is the Alcon Fidelis, that is, this is a portable simulator. They are mainly providing it for CMEs, and it was available in the Drishti here also, and through this you can see the OT setting, and the same, the hand pieces and all are same with the foot pedal. So simulator advantages are there are no collateral damage. You can repeat every step till you get it right, and there's a performance report at each step, like where you went wrong, how can you correct the step. So you can correct each step and do it again, and the trainees become more confident. It shortens the learning curve and decreases the trainer burden also. So another study which was conducted like this was a set of postgraduates. They had 1 week residency training at Mumbai, and one group was not trained. They were trained in the parent hospital itself with wet lab, and they were again assessed for the 20 cases. And this is the control group, and this is the simulator group. The orange one is the control group, and the blue is the simulator group. So all the steps, the complications were much reduced. So why not include the simulator training in the postgraduate curriculum is our question. So the one disadvantage is the high cost. So the cost, like some societies can take it up, and we can provide these facilities to the postgraduates. So we should incorporate simulation training in our curriculum. So thank you. Thank you.
Wonderful presentation, Sharika. Indeed an eye-opener, especially for the new PGs. This will be a great opportunity. As you said, let's hope at least a few district societies take up this as an initiative. So the next speaker is Shrikant. Over to you. He has his own setup. He's in fact a multi-talented and a great speaker as well. Over to you.
Thank you, sir. First of all, thank you for the opportunity. So now you learned the whole aspect of FACO, dealt with dealing difficult cases, customized IOL. Still, you have to get patients. Otherwise, we can't do FACO. No? If you are in a corporate hospital, yes, you will get patients. There also, the patients will choose the most famous doctor. So my topic is building a successful Phacoemulsification practice, ethical marketing and patient education. So why marketing and patient education matter? There were days only a phaco surgeon was available in the town, so all patients will come to him. Gone that era. Now we know everywhere there are phaco surgeons, so it's very difficult to get the patients. You may be a good surgeon, but the public should know about that. There comes the marketing. But the marketing, it's not like selling the products. We are actually showing our service and skill. So it should be ethical. So that area is actually a little bit confusing. Many corporates, even hospitals are now advertising. So we should not advertise. We can actually market, or we can publish our skills and our services. So visibility and trust are essential for building a thriving surgical practice. So we should balance the ethics and our business objectives. And we know educated patients are more likely to make informed decisions. So there are some core principles. So you have to be very transparent to your patients. So your all communication should be very transparent, and it should be accurate. And you should follow the regulatory guidelines. That is actually different in the different part of the world. So you should actually know about the regulatory guidelines, and you should follow that. And you should keep a patient first focus, not a surgeon first focus or a hospital first focus. Your main priorities are to the patients. And to market yourself, definitely you have to update your skills and knowledge. Then for that only you had the past talks. Okay, so you should always keep update your skills and knowledge. And there are offline presence as well as online presence. Offline presence is actually starting from the OP, because your patient should come to you. So in the OP, always try to make a face-to-face communication. Educate the patient. Now the many junior doctors are educating the patients, but they are all explaining all the complication, everything, and last patient will be scary. Do not make them scared. Just educate. Don't over-educate. You can use accessories. You can use slit lamp photography. You can use pamphlets and interactive boards. If you have set up, you can use interactive boards. And allow sufficient time to clarify the doubts. And communication should be tailored to each patient. You can't tell a 90-year-old patient like, yeah, you have a cataract and we are implanting a multifocal lens in you. Nothing. But you can tell that the same to a patient, a 40-year-old patient with cataract. So your communication actually should be tailored to each patient. That you will actually adapt with your experience. And networking for growth. You should not be an introvert. You should collaborate with other healthcare providers. For that, actually, you should not badmouth others also. Then only you also will get patients. And you should expand your reach and attend medical conferences and contribute to research for credibility. That's why I came here. And create a professional online presence. Because nowadays, everyone is referring internet, especially mobile browsing, rather than the computer browsing. So create an online presence. Develop a professional website with essential components. Not only for hospital, even for a surgeon or a doctor, you can create your own website. You can give that to the patient. Nowadays, there are very easy apps and easy QR codes available for that. So create a good website and maintain a positive online reputation. You can create an online reputation by negativity also, but create a positive online reputation to consistent. That is very important. It should be very consistent and ethical engagement. So, online tools, you have to get more views and visibility and get more followers. You can use social medias like Facebook, Instagram, LinkedIn, YouTube. And the medias, that's videos, live videos, you can go live, you can do surgery videos, you can write blogs, and you can give interviews and give educational videos, awareness, and skill showing contents. And you can create a Google page, ask for genuine reviews, and if there are any negative reviews, address it properly. And content marketing. So you should create good contents. You take your time and write up the contents, what the patient needs. You have to genuinely educate the patient and try to become a personal brand. Now the era is of personal branding, like Yusuf Ali, Bobby Chemlo, they are actually personal brand. Once you become a personal brand, the patient will believe in you. He will come to you and he will go to the doctor who you will suggest, okay? And be consistent. All this content making, you should be very consistent. You should take good quality videos. Don't take these 720p videos. Now people are not interested in that. Take good quality videos, invest some money for that. Short duration, because the better viewability is for less than 1 minute duration videos. And you can use regional languages because you are interacting to the common people. That's also according to your market. So this is just my way. You can see these are my website blogs. I am updating it continuously. The last blog was on November 16th. And this is my Instagram page. There are less than 1 minute videos. And this is my educational video. I used to do that. And my Google page, you have to get good reviews. Okay, so you can do videos, educate, blogs, and reviews. Okay. And avoid promotional tactics that may seem unethical or overly commercial. For example, Dr. X did 10,000 successful phaco. That is actually factual. You can measure that. It's ethical also. But if I say that Dr. S is the best phaco surgeon in Kerala, that is very much unethical. Because we can measure that. Or we can't tell that. How can we tell that? But there are institutions showing that. And there are some, especially alternative medicine, they will say, we put this drop, we can cure RP. Don't use that, because false or exaggerated claim we provide absolute cure for all disease. That is also unethical. So this is one of the example. Reebok actually once told their easy tone shoes can cure some leg problem, but they had to pay 25 million for each customer. So here is the takeaway. Making bold claims may be tempting, but that is not worthful. So communication, this is not patient education, this is to communicate with your patient. After they go from Europe, you have to communicate. You can use email, you can give your WhatsApp number, maybe your business WhatsApp number. You can use personalized apps. Now there are so many software which includes personalized apps. You can give YouTube link and you can reply to the videos. You can use Twitter, even you can use text messaging. I am personally using email and WhatsApp for my patients and I used to reply for all that. That is to communicate with your patients. And patient education. You can host workshops and webinars to inform patients, and you can maybe practice a meetup with your patients. After your successful patients, you can arrange a meetup and provide clear pre and post-operative instructions. And building trust through patient stories. You can publish your patient stories and testimonials, but you should take prior, proper, informed consent. So you should go for community engagement. You can partner with local healthcare organization, and you can also provide our free health camps to build goodwill and trust. And you should measure the marketing effectiveness by taking the feedback, and there are in FB and Google, you can use statistics also. navigating ethic challenges, handle the patient complaints with professionalism and empathy, stay updated on regulatory changes. There can be changes to ensure compliance. And some practical tip, have a written marketing plan for short term, medium term and long term. Then only you will be consistent. Tune up your recall system. You should follow up your patient. Demonstrate availability, affability and ability. Get out in public again. Talk to the patients. And maintain a commitment to the quality. Use technology in marketing. Thank you.
As usual, wonderful and a natural presentation. It has a lot of take-home messages. Thank you, Srikanth. So that marks the end of the session. If there are any doubts that can be taken up, I request all the speakers to come to the front. Can be seated in front. Yeah, Sharika, what's the cost of implementing a virtual reality session? How much would it cost? Like, how does the system work?
Last time they had brought it in Amala for a month. Like it was 6-day course for each postgraduate, 4 postgraduates in one session.
Okay.
And for one postgraduate it was around 20,000.
Okay.
So that was why they had registered, but then later they dropped off. So
Okay.
that is
Usually,
one cost.
like, let's say if, as you said, if a district takes up the mission, how much would it
That
cost?
we have to inquire with the,
Inquire.
yeah.
Fine.
Usually this Alcon Fidelis is giving free of cost. But they are not conducting as a full session. They are just for 2 or 3 days they bring it and then they take it back. Yeah, that we can train a lot of postgraduates together. So Alcon Fidelis is one which we can take. I'd ask them also. They are willing also actually.
Yeah. Take up. Okay then. So we'll tie up the session. Thank you all. Thank you. In fact, we had a lot of listeners this time. Thank you.